Healthcare disparities. The United States is a diverse nation and is expected to become substantially more so over the next several decades. Healthcare disparities. The World Health Organization, also known as the WHO, defines healthcare disparities as the difference in healthcare outcomes that are closely linked with social, economic, and environmental disadvantage. These are often driven by the social conditions which individuals live, learn, work, and play. Racial and ethnic minorities experience disparities across a significant number of health status measures and health outcomes. These racial and ethnic differences are driven by issues such as income, education, and work status, as well as poor housing, neighborhood segregation, and other environmental factors within communities. But disparities in health status and outcomes may also result from failures within the healthcare system. Problems accessing services and lower quality of care for minority populations clearly impact the health of these individual populations. Reverend Dr. Martin Luther King once said, "Of all the forms of inequity, injustice in healthcare is the most shocking and inhumane." This quote from Martin Luther King Jr. was made during a 1966 press conference in connection with an annual meeting of the Medical Committee for Human Rights, and it still rings true today. Let's continue to talk about some definitions so we know exactly what we're talking about. Disparity. This is the lack of similarity or equality, any quality difference, or the condition of being unequal. Health and health care. Health is the state of complete physical, mental, and social well-being. Healthcare is the prevention, treatment, and management of illness and the preservation of mental and physical well-being. Services are typically offered by the medical allied health professions. The determinants of health include behavior, physical environment, social environment, biology, and the individual. Social determinants of health include education, food, decent and safe housing, affordable public transportation, health insurance, and access to clean water, sanitation, and non-polluted air. Within the United States, some of the leading causes of death are heart disease, cancer, accidents, and diabetes. So why is this important? It is important to look at indicators of community health. We do this by looking at health disparities, health inequalities, and health inequities. Many Americans are in poor health and do not receive the best medical care. While these problems affect people of all groups and walks of life, the challenges are especially acute for racial and ethnic minorities. A myriad of research studies and reports have documented that minorities are in poorer health, experience more significant problems accessing medical care, and are more likely to be uninsured, and often receive lower quality health care than other Americans. These differences may be caused in part by factors such as income, education, and insurance coverage. But even after adjusting for these determinants, disparities often persist. Given the rapidly growing diversity of this nation, an increasing number of minority Americans find themselves at risk of disease and not getting the care they desperately need and deserve. The current population is approximately 67% non-Hispanic white, 12% Black or African American, 14% Hispanic, 1% American Indian or Native American or Alaskan Native, and 4% Asian. The United States Census Bureau projects that by 2050, populations that have historically been called minorities will make up nearly 50% of the total United States population. The biggest increase will be in the Hispanic population, which is expected to double between 2000 and 2050. If racial and ethnic disparities in health and healthcare continue unchanged, many more Americans will be at risk of disease and poor quality healthcare. Marked differences in income and education also occur along racial and ethnic lines. These factors are significant predictors of health status and the ability to obtain high quality health care. For example, Blacks or African Americans and Hispanics are twice as likely to live in poverty as white or Asian Americans. Similarly, we see that much greater proportion of Black or African American or Hispanics are nearly poor, meaning that their income is 100% to 200% of the federal poverty level. Using a different indicator of economic status, the median family income is $20,000 to $25,000 higher for non Hispanic whites and Asians than for Black or African American and Hispanics, and for American natives or Alaska natives. All of this is particularly remarkable given how income significantly influences health status, access to healthcare, and healthcare insurance coverage. Blacks and Hispanics have also had lower rates of educational attainment than whites and Asians. Higher educational levels have been linked to use of preventative services and longer lives. Communication barriers due to language issues may also influence whether minorities can get high quality health care. Approximately 1/6 of the United States population speaks a language other than English at home, and this number may rise as the proportion of Hispanic residents increases. Notably, the Hispanic population is much younger on average than the other demographic groups, with a median age range of 25.8 years compared with 38.6 years for the white population. As a result, it is likely that individuals of Hispanic origin consume less health care than other groups and are underrepresented in research on the use and quality of health care. Some disparities in health status and mortality. Minorities generally rate their health as poorer than whites. Non-Hispanic Blacks are the most likely of all races examined to report that they are in fair or poor health, with nearly 20% of non-Hispanic Blacks reporting this compared with 11% of non-Hispanic whites. Hispanic and American Indian or Alaska Natives are nearly as likely as non-Hispanic Blacks to report fair or poor health. 17.8% of Hispanics and 16.6% of American Indians or Alaska Natives rate their own health along these lowest categories. While disparities in self-reported health status narrowed for the minority groups in the 1990s, in more recent years the gap has not decreased, and in some instances has even increased. Most notably, the percentage of Black Americans who reported their health as either fair or poor increased by 5 percentage points from 2004 to 2005. While this data is still a little bit old, it's some of the newer data that we have to look at healthcare disparities. COVID has really put a damper on being able to look at some of this data. It would be really interesting to see what has happened, especially with COVID. Many Americans lost their jobs, and life was altered exponentially with the global pandemic. Continuing on, Blacks are also more likely to have chronic illnesses or disabilities, with almost half reporting such a condition. The disparity in chronic illness between Black and white individuals persists across income levels and after adjusting for age. Black individuals with family incomes below 200% of the poverty level are 26% more likely to suffer from a chronic condition than are white individuals, while both Black and white individuals with incomes at or above 200% of the poverty level are less likely to be living with chronic illness than their poorer counterparts. The disparity between Black and white still exists. In fact, it is greater at this higher income level. Individuals identifying as Black or African American at or above 200% of the poverty level are 40% more likely to have a chronic illness or disability than are white. Life expectancy is another measure commonly used to gauge the health of populations. Since the beginning of the 20th century, life expectancy at birth in the United States has increased, and the gap between Blacks and whites has narrowed. However, the disparities still exist. In 2003, the life expectancy at birth of white individuals was 78 years, a full 5.3 years longer than the life expectancy for Black or African Americans. Many factors may contribute to this disparity, including higher rates of infant mortality, HIV, homicide, and heart disease in Black or African American populations. The gap between Black and white Americans for life expectancy at age 65 is smaller, but still persists. When examining infant mortality as an indicator of the health and well-being of a population, Black or African Americans are by far the worst off among all the races or ethnicities examined. The infant mortality rate for non-Hispanic Blacks in 2003 was almost 2.5 times greater than for whites. American Indian or Alaskan Natives also had higher infant death rates than non-Hispanic whites. These two groups were more likely than whites to have low birth weights and very low birth weight babies, conditions which are closely linked to infant mortality and which can be diminished with timely prenatal care. Perhaps not surprisingly, non-Hispanic Blacks and American Indian, Native Alaskans have had the lowest percentage of pregnant women receiving prenatal care among all the groups examined. Little progress appears to have been made in reducing infant death rates among all races and ethnicities, with a very slight decline, less than 1 percentage point, in an 8-year period. Although improvement has been minimal, the infant mortality rates for Black individuals has declined slightly more than the rates of other groups. Infant mortality rates are smaller for all racial and ethnic groups for mothers born outside of the United States. The most substantial difference is seen in the Black population, where the infant death rate for U.S.-born women is 14.2 per 1,000 live births, compared with 9.1 per 1,000 live births for foreign-born